similar. So this is the diagonal branch. Usually there will be more problematic things in the AVL and lead 1, and there will be a depression in V1 and the hyperacute TVs in the lateral lead signified with the TV inversions in the 2, 3 and AVF, signifying that either diagonal branch or the first OM, higher OM or ramus, whatever you call, can be under problems. Either ramus or first diagonal or the first OM is considered as the significant occlusion in this prominent AVL elevation. This is posterior LMI. As I told, if you invert it, it will be similarly sealed as the diagonal branch. So it is the posterior LMI. Most probably it is the PDA or the PLV branch which is getting occluded, and you can see significant changes only in V1, V2, V3. Other than that, nothing else is shown. Like 2 and AVF may show slight elevations. You may think that it is the inferior MI, but if you can see, PR is normal, the heart rate is normal, and it is absolutely restricted to the dissimilarity in the reciprocal changes are very high when compared to the primary changes. If you consider this as the primary change, like T2, 3 AVF is considered as the primary change, the reciprocal changes are more than 3-5 millimeters depression, but the actual elevation is not more than 2 millimeters. So it should be significant that the whatever is there in the V1, V2, V3, that is, if you can take V7, V8, V9, there will be elevation in the leads. Okay, this is also posterior LMI, same taken from lead 7, 8, 9. As I told, if you take lead 7, 8, 9, you can show that see that there is a huge ST elevation more than the inferior leads. So it is posterior LMI. Similar posterior LMI ECGs. Similar V1, V2, V3 depressions. So isolated depression of V1, V2, V3 should not be left out like just ischemia. It is ongoing ischemia, and there is bad thing that it may die. So valence type 1 or whatever we had not seen in the previous this one. This is what is called the biphasic T wave. But what is very important is the axis will be almost normal. Slight left X, maybe the patient is having LVH. But other than that, progression of R wave is good, and there is no other Q waves in any of the leads to signify that there is an earlier MI, and there is no prominent changes in the AVR, signifying that the patient needs to be tackled with either other diagnostic evaluation or quickly into angiography to get into the conclusion of what is going on inside. Similarly, there is a deep TV inversion in the anterolateral leads, which I had already discussed. Everything appears to be okay. Slight left axis deviation is there. There is no QOS in any of the leads. From V1 to V6, there is deep TV inversion, symmetrical. History of chest pain and ECG during the episodes will confirm what is going on. Or otherwise, you can just go ahead and get an angiography to rule out the proximal LAD occlusion. This is what is devenous TV changes. You can see that there is a upsloping ST depression, upsloping ST depression, upsloping ST depression, upsloping ST depression in most of the layers with AVR elevation being seen, and there is a hyperacute T waves, like similar to the hyperkalemia. If you can see and there is no angina is there, and if there is no ST depression, it will appear like a hyperkalemia only. You would have to check potassium also, but usually potassium is the cause of all these things, so you can conclude that the patient is having demeasured sign, but it is one of the marker of, it's like Valence syndrome, it is one of the marker of early acute interval MI, but while Valence it is the critical stenosis, but here it is the actual MI. Thank you.